An induction is a process or procedure typically guided by your care provider to help you have your baby. It can happen in the hospital or birth center, or it can happen at home. There are a number of reasons why an induction could happen. One reason might be you've gone over your estimated due date. So that means beyond 40 weeks. Another reason why could be because your water has broken, but there aren't any contractions to support the labor process. Another reason why you might have an induction is because you actually want one. In 2018, there was a study done of pregnant women who had decided to have an induction even though it wasn't medically necessary. The outcomes from that study showed that choosing to have an induction after 39 weeks didn't increase their rate of having a cesarean birth or having their babies admitted to the NICU. So, if you feel like an induction is something that you would like because you're feeling anxious and not sure that you can manage waiting for labor to start, we now have information that tells us that that's actually safe. One of the reasons why an induction might happen could be led by your provider. Oftentimes, depending on what's going on in your pregnancy, your provider might say to you that it seems like it could be safer for your baby to be outside of your body than in. That recommendation can come up if you've gone over your due date, so over 40 weeks, or if you have gestational diabetes, signs of high blood pressure, or signs of preeclampsia. Other reasons could include low amniotic fluid at the end of your pregnancy, or unreassuring heart tones, also known as heartbeats, from your baby. As I said earlier, inductions are typically led by your care provider. So that would be your OBGYN or your midwife. That said, there are self-led induction options as well that still might have someone else involved, but it won't be your traditional care provider. Examples of that would be acupuncture, visceral manipulation or chiropractics, or sex with your partner. Let's talk about inductions that will be guided by your care provider. So that means your OBGYN or your midwife. These inductions could happen at the hospital, the birth center, or at home, led by your midwife. It's really important to understand that inductions doesn't mean that your birth is going to go faster. Inductions, I always have said, are a long game. And typically, I always say to plan for anywhere to 12, sometimes up to 72 hours from the time your induction starts to when you'll actually meet your baby. Your provider is going to decide on what kind of induction option might be best for you based on something called a Bishop score. And the Bishop score is a number of evaluation points that put together can determine whether or not having an induction would result in a vaginal birth. Here's what I want you to keep in mind when it comes to the Bishop score. If you have a high Bishop score, so 8 or more, it's on a scale of 0 to 13, then the chances of you having a vaginal birth are really high. If you have a low Bishop score, so anything under 6, there's a really high possibility that you could have a cesarean birth. Now, it's important to keep those two things in mind because, as I said, inductions are a long game. And if you have a low Bishop score and knowing that the induction is going to take a long time, it could be a much more supportive decision to explore what a gentle cesarean birth would look like versus going forward with an induction with a low Bishop score. And the reason why I'm making that recommendation is that birth is a moment. It's taking you from one stage of your life to the next. But that next moment that you're going into, which is new motherhood, is so demanding. And so I would really prefer for you to have a much more contained and shorter experience with a gentle cesarean birth versus having, say, a 72-hour induction that only ends in a cesarean birth, which is obviously a big procedure, and then moving into the first few hours and days postpartum more exhausted than you need it to be. Now, if you have a high Bishop score and you might be feeling nervous or reluctant about having an induction, I really want to support you there as well. Because if you have a high score, there's a pretty good chance that you could have a vaginal birth. And so it's really about kind of gathering your energy and getting into the right mindset for the long journey ahead. Now, there could be an instance where your induction could be swift, and we can get into that in more detail when we talk about the 5 evaluation points used to determine whether or not you're a suitable candidate for an induction. The evaluation points used to determine your Bishop score are effacement, dilation, consistency, position, and pelvic station. Let's talk about effacement. Effacement has to do with your cervix. Your cervix is the opening of the uterus. The cervix opens into the birth canal or vagina, which is where your baby will travel through and be birthed into the world. Now, when it comes to effacement, effacement is all about the shortening and the thinning of the cervix. This cervix, I would say, is probably around 30 to 40% effaced because it's still pretty thick and the cervix is still quite long. This cervix is now considerably effaced. Notice that the bottom portion has melted away completely and it's also dilated. Now, dilation is the opening of the cervix, and the cervix opens during labor from 0 to 10 centimeters. This is a cervix that is completely dilated to 10 centimeters. Now, what I want to show you is the difference between the two cervix models. The first cervix model I showed you over here has a very thick, long, protruding cervix, and the cervical os, the hole, being just dilated probably to around 2 centimeters. The cervix model that I showed you next is dilated to 10 centimeters, and notice that the longer protruding area is now melted away. That's because effacement is now also complete. This should give you an idea of what's happening when your cervix is dilating and when your cervix is effacing. In terms of consistency, consistency has everything to do with whether the cervix feels hard or soft. The first cervix I showed you would feel more firm. A part of your body that would feel similar to the firmness of a unripened cervix, which is a term that's used to describe a cervix when it still has some work to do, would be the feeling of the tip of your nose. Now, the cervix, as it ripens and gets softer, it starts to feel more like the inside of your cheek. The second cervix I showed you would be considered a softer cervix. In fact, there's not that much cervix left actually because it's effaced and dilated to completion, which is a term that would be used when you reach 10 centimeters of dilation and 100% effacement. When it comes to positioning and pelvic station, these two elements have to do with the position of your cervix in your pelvis and then the position of your baby in your pelvis. So when it comes to cervix positioning, your cervix could either be more forward in your body, so more anterior, or it could be more posterior in your body, which would be more towards the back. And in terms of pelvic station, your baby could be above 0 station. So that would be somewhere around -2 or -3. Or your baby could be a little lower than 0 station, maybe at +1. Now, how does your provider figure out how dilated you are, what your effacement is, the consistency of your cervix, its position, and where your baby might be in your pelvis? Well, they do something called a cervical exam, which means your provider will probably take a gloved hand, placing 2 fingers into your vagina. And once those fingers are placed, what they're looking and feeling around for is your cervix. Those fingers are circling the cervix to see how dilated or effaced it might be, its actual consistency, and if you're dilated slightly, they might be able to feel in and see where your baby's head is at the bottom of your uterus and how it's applying to the cervix. That's how your provider is able to determine what's happening with your cervix and where your baby is in your pelvis. And with that information, they're able to determine your Bishop score. Let's talk about the procedures that can be used to help induce labor. One of the procedures is using something called a Foley bulb. This can be done at the hospital by an OB or a midwife, or at home by your midwife. The point of a Foley bulb is to irritate the cervix, open it to at least about 4 centimeters, create prostaglandins in the system, and then to also hopefully get the release of oxytocin in the system, which will then help start true contractions. Now, the placement of a Foley bulb can be somewhat uncomfortable. So using comfort tools to help you feel more at ease while it's being placed and while it's in might be really helpful. And the reason why it can be uncomfortable when it's in is because the cervix actually has a bunch of nerve endings. So as it's being irritated or opened, it does create some feelings of pain or discomfort. Now, let's actually go through what happens when a Foley bulb is placed. To place a Foley bulb, a rubber catheter and a syringe full of sterile water is needed. The rubber catheter is placed into the vagina and then into the cervix. And once it's placed, the syringe fills up the catheter with about 12 ounces of sterile water. Once it's there and filled up, what it's doing is irritating the cervix and helping to release prostaglandins, which is a hormone that helps to continue to soften the cervix, and hopefully also setting off the release of oxytocin, which are hormones that help to start contractions. Actually, the combination of oxytocin and prostaglandins is what helps to start true contractions in the body. And so when the bulb sits in the cervix, irritating the cervix to continue dilating and opening, that's when those hormones are released, and the bulb stays placed until about 4 centimeters of dilation, and then it falls out. Another induction method is breaking the bag of water, or AROM, artificial rupture of membranes. And what that actually means is your doctor or your midwife will use something called an amnio hook. The amnio hook is a long plastic tool with a small hook on the very end. An amnio hook can only be used if you've had a little bit of dilation and enough effacement for the tool to actually get inside of the cervix. Once it's inside of the cervix, it'll be moved around to contact the membranes of your amniotic sac. The amniotic sac is a sac that holds in the amniotic fluid inside of your uterus. And the amniotic fluid also provides nutrients to your baby and helps to filter out waste. Once the amnio hook is in the vagina and has found its way into the cervix, the hook part of the tool makes a small hole in the amniotic membranes, releasing the fluids, allowing your baby's head to come further down and apply pressure to the cervix, helping it to continue effacing and dilating. Now, we've talked about procedures that can be used to help induce labor, but now let's talk about medications that can be used to help induce labor. The medications that are available are Cytotec, Cervidil, Laminaria, and Pitocin. Now, it's important to keep in mind with medications and inductions that these medications are given under the supervision of your care provider. And for the most part, you will have to have these medications placed or given to you in a hospital or birth center setting, meaning that when you go in to have an induction, you are typically admitted in the hospital or birth center until you have your baby. And I mention that only because oftentimes there's some confusion around inductions, and sometimes people have this impression that you can have the medication and go home and then come back. That's not the case. Once you have the medication, you will be at your birth environment until you birth your baby. Cytotec and Cervidil are prostaglandin-based medications, meaning they are medications that release a synthetic version of that hormone into your system in order to help with effacement of the cervix, meaning the softening and the shortening. Cytotec is a small pill that's crushed and placed inside the vagina behind the cervix. It's usually given every 4 hours while the monitoring of your cervix and your baby happens. If your cervix continues to soften and continues to ripen, more Cytotec is placed every 4 hours. The second prostaglandin medication is Cervidil. Cervidil is a flat wafer that kind of looks like a tampon. It has a little string at the end, and it's placed inside the vagina behind the cervix and left there for about 12 hours. Now, Cervidil, I would say, is a much more gentle induction medication, primarily because once it's placed, it can be pulled out if your baby isn't tolerating it well, which could be shown by poor fetal heart tones, or if your body's not tolerating it well. Versus with Cytotec, once it's crushed and placed behind the cervix, it's in the bloodstream and it can't be removed. So in terms of negotiating your induction opportunities with your care provider, asking to use Cervidil might be a better choice if it's available at the birth environment you're going to be at. Laminaria is another option that could be offered to you to help ripen and soften the cervix. The thing about laminaria that's interesting is that it could be offered in a couple of different birth environments. If your midwife is a certified nurse midwife and a nurse practitioner, meaning that they are able to prescribe you medication, then you might be able to have laminaria placed at home. And once that laminaria is there, it can remain for 24 hours, doing a very similar thing to what Cytotec and Cervidil do. However, laminaria can also be offered to you by your OBGYN at the hospital and can be placed and left for no more than 24 hours. Again, laminaria is probably a more gentle induction method alongside Cervidil, followed by Cytotec. The final medication that can be used to help induce labor is Pitocin. Now, Pitocin is synthetic oxytocin. Oxytocin is a hormone that helps to promote contractions in labor. Now, what you want to keep in mind about Pitocin is going to be given to you via IV through a pump. When Pitocin is started, Pitocin is given at a really low dose, and you're only going to be offered Pitocin if you have significant dilation, so somewhere around 2 to 3 to 4 centimeters. If you don't have progressive contractions, Pitocin would be how you would start your induction. That said, Pitocin can also be a part of a layered augmentation plan. Augmentation means doing things to your labor to move it along. Pitocin has a lot of complex connotations attached to it. I'm sure you've probably heard people say, oh, don't get Pitocin, avoid it at all costs. It makes your contractions horrible. You really don't want to use it. Now, what I actually want to share about Pitocin is that Pitocin doesn't actually make your contractions more intense. What it does is it turns up the volume before you might be ready. So let me explain that a little bit more. Pitocin is only going to make your body create the contractions that your body is able to make, but it's not very sophisticated. So what Pitocin can do is get you to the strongest contractions your body can make without you having the rest period or the adjustment period. When you have contractions on your own without any help, your body goes through these different stages of labor, early and active labor, where the contractions start off really soft and really spaced apart, feeling like they're happening more in the low back, making their way around to the front of your belly by the time you're in active labor. And then active labor contractions are more tight, they're more intense, but you've had a couple of hours, maybe even a couple of days to adjust to that change of intensity with contractions. When you get Pitocin within 1, sometimes even 2 hours gets you to the height of an active labor contraction without that gentle pacing that early labor allows you to have. So that reporting that people give of it makes your contractions so horrible actually does make sense, because when you use Pitocin, you don't get that time to catch up. And so it can feel like the contractions are worse when in fact, your body's just working at max versus getting to its max. So That's definitely really important to keep in mind when thinking about having to have Pitocin as a part of your birth experience. That said, Pitocin's going to be given to you on a pump, and that pump is going to be titrated up, which means the dosage will slowly over time, usually every 20 minutes, sometimes every 40 minutes, be increased to get more Pitocin in your system to get the contractions where they need to be. You can always ask for the pump to be turned down if the contractions feel too intense, or to be turned off and see if your body has kicked in and is starting to make contractions on its own. So there's flexibility around using an intervention like Pitocin, and that's really going to be something that you'll want to incorporate into your birth preferences when you're working with your care provider, and to talk really clearly about how Pitocin is going to be used. And what I've seen over many years is when Pitocin is used with that level of consciousness and refinement, it can be a really amazing and helpful tool to help bring your baby into the world. Now that you know the procedures and the medications involved in an induction, I think it's also important that I share some new data with you. In 2018, there was a study done on around 6,000 pregnant women where they were given the option of having their labor induced at 39 weeks. These inductions were not medically indicated, meaning that these women decided to have an induction because they felt like it, and it felt like the right decision for them and their lives at that time. The outcome of the study is really fascinating. The fact that these women chose to have their labor induced at 39 weeks didn't increase their possibility of having a cesarean birth or increase the chances of their babies landing in the NICU after their birth. The reason why these outcomes are so fascinating to me and also are really liberating is because of the complexity of the culture that we live in. What I've learned and seen over the years is that it can be really hard to wait for labor to begin on its own. Ideally, it's something that I do encourage because allowing your body to go into labor spontaneously means that your body is actually ready to go. And everything that comes after that should be this connected cascade of events that helps you to birth your baby with very little interrupting that. That said, sometimes psychologically, it can be really supportive to know that this is the day that I'm going to go to the hospital or the birth center, or when my midwife is going to come to my home and help me go into labor. Having that date in mind, knowing how to set up your environment, knowing how to set up your partner if you have one, or your chosen family or friends or support team, can reduce a lot of the anxiety that comes with that waiting period. So now that we know through a very large study that inducing at 39 weeks doesn't create any of these risk factors that I think for many, many years have circulated around the idea of inducing at 39 weeks, my hope is that it helps empower you to make the best decision for yourself around how you want to move into your labor and birth experience. If it makes sense for you to be induced at 39 weeks, I want you to know that the risks around that are very, very low. That said, if you don't want to get induced at 39 weeks, there's absolutely no reason to. You can just wait for your body to begin labor on its own. Now you have all the information you need to navigate your decision-making process around an induction. The final thing I want to leave you with are a few questions you can bring to your care provider to unpack what your preferences could be around your induction. If an induction is recommended to you by your care provider, it's always important to ask why, and then also ask, what happens if I wait? Getting those two pieces of information are going to help you to make the right decision for yourself. Two other questions you could ask is, what if I choose not to have an induction at all? That's a good question to ask in order to get an idea about what your care provider's end game is when it comes to your birth experience if you're not open to any of the induction methods that have been offered to you. And then the last question to ask is, can I stop my induction once I start? Typically, the answer is no. And that's really important for you to know in order for you to make the best decision for you and the best decision for your baby. Overall, there are risks involved in choosing to have an induction and choosing to not have an induction for both you and your baby. So that's really important to get clarity on within yourself and with your care provider as you move through these questions.